we've just finished the first plenary session, which was really an overview of what the meeting is about, and I'm pleased to be joined by Maurice Sarano. Maurice is the course director, the director of the course. And Maurice, you just talked about the imaging revolution. Tell me a little bit about what your thoughts were.
Well, what we've reviewed is how things have changed over the years, and we had made some progress, but what is important is that the progress in imaging valve disease, in imaging the ventricle, in making diagnosis and referring patient for their treatment without the need for invasive methods is increasing, and our ability is increasing. For example, aortic stenosis, we now have that concept that aortic stenosis can be severe without high gradient, and now we have methods to quantify the degree of calcification, so this can come together with the Doppler evaluation and facilitate the decision making in people who are otherwise troubling with a low gradient, symptoms difficult to interpret, and so we have advancing things. Another issue that we reviewed in the imaging issue is that we have developed quantitative methods. It gives us number, but what do we do with the numbers? The numbers have to be interpreted. We have to be physicians and interpret these numbers. And so that means that, for example, if you see a patient with mitral regurgitation, a regurgitant orifice of 0.4 centimeters square or more, if it's organic MR, it's severe, but for functional MR, the threshold will be different. So the motto here is to say, each disease should be interpreted in context, and we should have a lecture of the number, not as a uniform number, but as a number that comes into the picture of the specific patients. So that was the sort of first part of interpretation of the imaging revolution, but the new part is the most exciting, development of 3D methods, right. The imaging that we can now quantify. We've just begun to touch on it, and we're now going to have numbers on how the valves change throughout the cycle, how we can measure the mitral aortic valve, comprehend what we've not comprehended over the years. It's going to be helpful in our comprehension, and the methods, the software, the engineering that takes place here is very exciting.
And you did a great, I mean, your presentation was fabulous. But you emphasize, I think, the important point, I just want to go back quickly, is that it's not one number, it's really an integration of the imaging with the clinical history and all that.
Exactly.
And you also mentioned that there are, we do have complementary imaging technologies, the CT especially.
Absolutely. Yep.
Do you see as we move into the hybrid OR arenas and all those, what's the role of each of those imaging modalities as we get the patient?
I think it's a very important point, because we have used TE in a very extensive manner in all these new techniques, but the problem is that you need anesthesia. And for people who, particularly in Europe, are now doing totally percutaneous with no incision and no anesthesia, the practice of having TEs makes it difficult. So now the imaging is switching back to transthoracic echo combined with a CT, with a fluoroscopy, and we're going to have a different world of imaging during the procedure, and we need to enhance what has been the key factor, the collaboration between the clinician, imager, and the interventional cardiologist and the surgeon to get the best modality for whatever approach is decided.
Okay.
And so we have to be open.
Yeah, and finally, I mean, I think you make a very valid point there, and I think that you emphasize, and it's true, that imaging is going to has played, but will play an increasing role in not only identifying which patients need which intervention, but the type of intervention and guiding that intervention?
Absolutely. The lesions that we see are critical. For example, in mitral techniques, the extent of the lesion is going to be essential in deciding what you do, surgery, repair, robotic versus clipping. All of that will be guided by comprehensive imaging. So we have to be one comprehensive imager, but we have to be doctors and make an interpretation of what we see for the good of the patient.
Fabulous. Couldn't say it any better. Thanks for joining us.
Thank you.